So, good afternoon, everyone. My name is Andrea Shipley, and I'm the project coordinator here at the Wyoming Telehealth Network. Welcome to the March 30th webinar titled Part 1 of a three-part series, The Nuts and Bolts of Getting Your Clinic and Your Patients Started with Telehealth. As always, we want to invite webinar participants to explore all the ways to get involved with the Wyoming Telehealth Network. So please do visit our website. You can see past webinars, and you can click on the Get Involved tab to see our special interest groups and more information about the Wyoming Telehealth Consortium. We would love to get you involved and continue to amplify our voice for healthcare access through telehealth. Join us in April as we dive into part 2 of this series that will feature a panel of nurses who will give attendees tips and tricks on telehealth workflow and how to surmount common barriers in telehealth. The webinar will be held Wednesday, April 27th from noon to 1. Today, we are lucky to be joined with our speaker, Faith Jones. Faith began her healthcare career in the U.S. Navy over 35 years ago. She has worked in a variety of roles in clinical practice, education, management, administration, consulting, and healthcare compliance. Her knowledge and experience span various settings from ambulatory to inpatient to post-acute. In her leadership roles, she has been responsible for operational leadership for all clinical functions, including multiple nursing specialties, pharmacy, laboratory, imaging, nutrition therapies, as well as administrative functions related to quality management, case management, medical staff credentialing, staff education, and corporate compliance. She currently implements care coordination programs focusing on the Medicare population and teaches care coordination concepts nationally. She holds a green belt in healthcare and is a certified lean instructor. Thank you all for being here today and offering your expertise and best practices to improve telehealth in Wyoming. Faith, take it away.
Thank you. Thanks so much, Andrea, for that. Sorry that intro was long. I would have sent shorter if I knew you were going to read the whole thing. Just kidding. So anyways, we're going to go ahead and get started here today. And I do live in Powell, Wyoming. I always like to let people in Wyoming know that. Yes, our company is in Tennessee and in Dallas, but I work and live out of Powell, Wyoming. Okay. So as Andrea talked about, we do have a three-part series today. Today, we're going to be talking about really using care coordination as that foundation for patient engagement and what that really looks like and how you can engage people in a care coordination program and take it to that telehealth level. And why we do that is because of all of the relationship building and take away the scary part of technology and all those kinds of things. That's what we're going to be talking about today. And then I will actually be the one who is facilitating part 2 in April. And I have 3 amazing care coordinators in the state of Wyoming that are going to share their journey and some of the things that they do in some of the workflows and being able to meet with patients and get them excited and interested in using some of the telehealth technology as well. And then part 3 you can see part 3 is there done by Maribel Frank. Okay. So let's start by talking about patient engagement when it's a really an important piece. And one of the things that as a nurse for a really long time, as Andrea pointed out so nicely, one of the things that I think we can do sometimes is label our patients and inappropriately in my mind, is that patients just aren't engaged. Patients aren't accountable. Patients don't care. I don't know what we can do. So there's all these kinds of things, but I want us to take a deep breath, and especially in our times where healthcare is very difficult right now, take a deep breath and think about what's happening with that patient. And I am going to focus a little bit on the elderly population, but this is true for all populations. I don't want you to think this is just elderly. It's true for all populations because they're getting bombarded. They're getting bombarded with information. It's really awesome that we have so many amazing specialists that can really help people take care of themselves better, but The specialists don't always talk to each other. They pretty much never talk to each other, and they occasionally talk to the primary care provider, but that's not even a given. And so when you start looking at patients getting information from here and there and everywhere, and nobody's on the same page, and when they get something, they don't know who to turn to and they don't know what to do, and they get frustrated. And sometimes, I don't know about you, but it even happens to me. If I get frustrated or overwhelmed, the easiest thing to do is to do nothing, right? It's not the right thing to do by any means, but it can be the easiest thing to do is to do nothing. And so we need to be really cautious about what kinds of information and how we are bombarding our patients and how we get them engaged. And so that's where care coordination really comes in. Care coordination really is about health promotion. We've worked in a sick model of care for so long, meaning that we take care of sick people is all we ever do. There's been lots more reimbursement now. Reimbursement's important. How we get paid for these things is important because that's how we are able to actually support and pay for the staff to do these things. So we really need to start thinking about health promotion. And health promotion and proactive care coordination really do go hand in hand. And when we talk about health promotion, we're really talking about health in general. We're not talking about just health care. And I think language matters. I think we've had lots of things that have happened in the past where we think we're saying the same things. We might be using different words or the same word, but we have different meanings. So I always like to make sure we're clear about the languaging. So, and the definition of health, quite frankly, is whatever the patient believes it is. Each of us have our own into our own personal, this is what I believe health is. This is how healthy I want to be, not how healthy you think I should be, right? So that's a really important thing when we're kind of looking at this. And to engage people, we need to make sure we're engaging them where they want to be. So this is the definition of patient-centered care. We've heard patient-centered care as a phrase. We've heard about patient-centered care. We've been using it for a long time. But I want us to take a minute here. And this it came from the the IOM, which is now called the National Academy of Medicine. And I want us to think about this definition. It's providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that the patient's values guide all clinical decisions. That's really an important thing to be thinking about. If giving health advice to people worked, everyone would be healthy, right? We might even take our own advice. Okay. So it's really important for us to be thinking about what is it that the patient wants, not just telling them what they need to do all the time. Talking at people and not talking with people is not helpful. That is not what is going to engage them. You might get the nod. Yep, I understand. Yep, that's something I'm willing to do. 6 months later, they come back and they haven't done any of it. And you get frustrated. And I get that. But we need to change our approach. And so the framework that I really like to use with care coordination, and I think this is going to be really important also with telehealth, and you're going to see that as we kind of get towards the end of this slide deck, but the framework is the 4 M's. This is an IHI model, comes from the age-friendly health system work. I referenced it down there at the bottom if you'd like to download the document yourself. The document is about 52 pages, but it's not overwhelming. There's lots of pictures. It's got lots of good information in it, but really focusing on what matters most to the patient. And when you start to have conversations with them about what they care about, what matters most to them, what is it that they want their health to be? They may give you some surprising answers that for you, that is the furthest thing that you would think is important at this time, but that doesn't matter. Right? What matters is not what you think, it matters what they think. So it's really important to understanding what matters most to the patient. And then we kind of do that in the framework of kind of a care plan. So really that's the patient goal. This isn't a nursing care plan that we're used to doing that has all the formal language and all these things. No, this is patient-centered care. This is their care plan. What's most important to them? What is it that they want to work on? And if you do have a practice that wants to be age friendly, patient, certified. There is such a certification, and I'll give a shout out to Ivanson down in Laramie. They are a certified age friendly practice. Dr. Biori and her practice, who's a geriatrician. And it really is important that everyone is paying attention to what matters most to the patient. When you understand that, that's how you can engage people, because you can understand what matters to them. And if you understand that, then you're engaging on their level. To say this is what matters to them, but I want them to do this, they're not going to be able to do that, or they're not going to be engaged in doing that. But over time, when you concentrate on what matters to them, guess what? We have found that their goals start to become more and more specific. They're willing to stretch their goal a bit. They're willing to take that next step because you were willing to work with them on what mattered to them first. Building relationships, building trust, that's what's important. And then we focus on the 3 areas that concentrate on where people have some of the most issues, and that's around medication, mentation, and mobility. So when we start talking about the interventions, or what it is the patient's willing to do, these are really great places to start. Now, you can have other things on there as well, but let's talk about your medication management. How are you taking it? Are you willing to switch to pill packs? Are you willing to switch to maybe using a med box so that you do remember to take your meds every day? So it's what the patient's willing to do around medication, mentation, and mobility. So I really like this framework, and I like to kind of put that out there because it's the foundation, I believe, of patient engagement. So I also want to show you this really quickly because care coordination is not a flash in the pan. So for those people who are holding out and thinking, oh yeah, that too will pass, and at some point I'm gonna, we'll go back to doing healthcare the way we used to. That's not true. Pretty much, although I don't have a crystal ball, pretty much I feel like I can say solidly that we're not going backwards. Care coordination, the growth and development of this all started around that annual wellness visit in 2011. And you can see every single one of these are changes to the federal regulations, changes to CMS, and it started 2 years later, 2 years later, then look, from 16 on, every single year, something has changed, something has been updated. And guess what? Every single one of these modalities, every single one of these additional service lines is a reimbursable service line. So not only is Medicare saying we need to do this value-based care, they are paying for it. So when they're putting their money where their mouth is, so to speak, this is something that it just keeps getting bigger and is going down this road. So it's time to jump on as quickly as possible into this world. So how well is it working? Well, this is the other really exciting stuff. This comes right out of the Federal Register of 2019. And you saw that earlier. We started doing care coordination in general in 2011. But then in 15, TCM, transitional care management, was in 13. CCM was in 15. Advanced care planning was in 16. So putting that in perspective, by the 2019, when they pulled this all together, 3 million unique beneficiaries have actually received these care coordination services in some sort of combination of these 3. That sounds like a lot of people, so it's a pretty good number, except it really is only 9% of the Medicare population, right? We're talking about 35 million people actually qualify for such service. So there's lots of room for improvement here. But really important to see these noted outcomes. It really does reduce readmission rates. It really does reduce lower mortality. It really does decrease healthcare costs. And I will tell you, it really does increase patient satisfaction because patients love having that single point of contact, being able to build that relationship with people. So I'm just really quickly, I'm not going to go through this in detail because I really want to get to the part of relationship and telehealth and technology. But I did want to make sure we set a really good foundation. So these are the elements to putting in a chronic care management program. So I want to draw your attention to the fact that it does require patient consent. So you'll see that's the 4th bullet on the right side. And that means patients need to agree to enroll. I always like to say you can't do care coordination for someone behind their back. If they don't want it, they have to be an integral part of this, right? So patient enrollment is key. And that's how we start getting patient engagement, by talking to them, by finding out what's important to them. That's where we do that care planning, where we have all of this to say, we would really like to help you stay on track. We'd like to help you stay on the track you want to be on. And that's what we talk about when we talk about getting patient consent. For some people, they're like, oh, I wish we didn't have to get consent. It's such a hassle. Patients say no. And it's like, well, let's talk about then how you're actually addressing consent. The regulations make it really pretty simple. It's simply about patient agreement. So if you think about patient consent as engaging the patient in their own care, and that they're agreeing to be engaged in this care and to work with you, if you change that in your brain and you change that in your thought process from this informed consent process to getting the patient engaged and getting the patient to agree to be a part of the care, telling them that you're there for them, holding their hand along the way, so to speak, and they are going to be able to work with you. I think when you change your thoughts around patient consent, you change your approach around patient consent, you're going to find that you're going to have a whole lot more patients that say yes, because that's really the part of being engaged. But sometimes people just aren't ready, and sometimes they will say no now. But if they've said no once, doesn't mean that you can't approach them again in the future if they have another issue or something else happens. So keeping that in mind. This is a time tracking service line. Okay. So it is I like to talk with people about you track time for the things you're doing. And if you get to 20 minutes or more in a particular month, the month is billable. Remember, I said language matters. Language really matters. Okay. So saying things like, we can bill for this phone call. And people will call me and say, hey, can I bill for in a CCM program? Can I bill if I'm calling the patient about XYZ? And I will kind of, to be a little bit of a snit, I think I say no. And they say, well, I thought you said we could cover that. I'm like, no, I never said you could bill for that. I said you could track time for that. And they go, well, that's what I meant. No, that's really important that you mean what you say and you say what you mean, because you can track time for all the things you do with or on behalf of the patient, but you may only bill for a qualifying month. And why is that important? It's important because we don't want patients thinking we are billing them for every encounter, because we're not. We're not billing them when we call to check up on them. We're not billing them for all of these pieces. That has a very different thing in our brain when we say that. We are care coordinating and we are tracking time throughout the month, but we only bill for a care coordinated month. That's how it works. So I think language is important, that we put the language around that. Okay. So what is the purpose, right? So the purpose of care coordination, it's more than just time tracking and calling the patient and getting in your 20 minutes. It's really about getting the patient organized, getting their care organized so you can deliver the right care in the right way to the right patients and the care that they want to receive. So care coordination, yes, we do time tracking, but we really build those relationships so we can really figure that out. We like to go through the record and do your research, right? What's the purpose of their visit? Let's read this last note, right? Then did we need to review any labs? Do we need to get the reports back? Review any consults? What's the follow-ups going to look like, right? So what's going on with this patient? What does the patient expect from the visit? That's really important. We can't make assumptions. So when we're calling patients before a visit, we'll want to make sure that they understand what this visit's about and what they can expect from this visit, and asking them so that we can assess their understanding of what's going to happen at this particular visit. So we start looking at those follow-up appointments and the right setting for the right follow-up. And if we really know our patients, we know what's important to them, we understand what this next visit's going to be about, we can then start to have conversations with the patient to say, this is a visit that, because the provider's going to go over with you all of your lab results, they're going to talk about what's going to happen in the future, what it is that you have some decisions to make around some things. This is an appropriate visit to be done by telehealth. Is that something you'd be interested in? Do you want this visit to be done by telehealth? right? So understanding the expectations of the visit and asking the patient and being on their page, like, is this something that can be accomplished by telehealth? Offering it to patients versus telling them this is a telehealth appointment, right? And then letting them know, but also understanding that, hey, maybe when people do telehealth and they really like it, right? And they're doing well with it, then they turn around and say, I'd like to make a telehealth appointment. That's not always the option either. Sometimes it's like, well, what's this appointment for? What's it going to be? Yeah, maybe that appointment is better to be in person, but maybe that appointment absolutely can be accomplished by telehealth. But you need to know your patients and you need to engage with your patients so that they understand what it is that they can expect from the visit and what the visit's all about. And that's how we make those determinations of telehealth visits versus in-person visits. And so that's a really important piece to have that relationship. So when we're first getting started with telehealth and people are maybe a little weary of it, I like to get started with those patients who we have relationships with. So working with those patients that are indeed in our care coordination program, you already know them. You already know what matters most to them. And it's a way to grow it from there. And then guess what? I always like to say, never underestimate the power of the coffee shop. Because once you've had somebody who's had a very successful, they loved that they had a telehealth visit in their home and it went really, really well, then what happens next is they tell their friends about it. And so then their friends aren't so afraid of getting a telehealth visit. Yeah, I think it can be good. No, I don't think I do have to see them in person. And yeah, it really worked out well for Mabel. So I think it's going to work out well for me. So that's really working with that population you have relationships with, engaging them and kind of going down that road. Now I'm going to switch gears just a teeny bit and I'm going to get into some of the nuts and bolts. So that's kind of that bigger piece, but I want to talk about some of the nuts and bolts and some of the things we can be thinking about as we go forward with telehealth with our patients. So first of all, technology. Again, one of the things, if I don't get anything else across to you in this webinar today, is don't make any assumptions. Okay, we do live in Wyoming, and we got to figure out, like, what is it that people are going to be using for their connectivity? Okay, so do they have Wi-Fi? Okay, do they have cellular service? Are they going to be using a hotspot? What does that look like? How is that connection going to work for them? Sometimes making sure that all of these connections are clear. Do not make assumptions for them. Making sure sometimes maybe they'll bring it into the office and they're like, well, here's the laptop I'm going to use, or here's my tablet. I will tell you, in our elderly population, tablets are super popular. So we have a lot of people that have their iPads, their tablets, those types of things. So have them bring them into the office and show them to you if they can do those kinds of things and get them started. So that is one option, and making sure they understand that. And then I always ask lights, camera, action. Okay, where is the camera? Is it enabled? Even just in the world of using Zoom meetings and those kinds of things, I am kind of amazed at how many people, I don't know why my camera's not turned on. I don't know where to turn it on. And then they get IT down and IT accepts and says, you don't have a camera on this computer. They assumed every computer has a built-in camera now. That's not necessarily true, right? So making sure that they have a camera. Where is it? Is it enabled? Is it turned on? Or is it something that they have to add in? So understanding all of those pieces. And then doing that sound check. This is probably the most frustrating piece to particular elderly population, but anyone, quite frankly, when they can't hear. They cannot hear. Where's the volume? Is there a microphone? Is it clear? And then the other part of that is, I want you to pay attention to, is privacy issues. If they are doing this in their home, which is so exciting and so fabulous that we can now do telehealth in the home, at least still, I'll say still, hopefully it'll be forever, but we don't have those 100% in, but right now we still can do telehealth with the patient in their home. If they are in a room or in a house where they live with several people, they need privacy, even from their own family members, right? So do they need a headset so that they can talk and they can hear what the doctor's saying versus being able to yell it out? So what does that look like? So really making sure they have all of these things in place is important. And then we want to pull this all together, right? So the patient has everything they need to have a successful telehealth visit, right? That's what we're going to be looking for. And Will they be better served for their very first one in particular if they had some help in the home? And you might be thinking, yeah, but who's going to do that? Who's going to go to the patient's home and actually get them set up with telehealth? And so, if this is somebody who you think likely they are going to be needing telehealth services and they would benefit from telehealth services well into the future, this is somebody that it is absolutely worth you working with them and setting up that successful telehealth visit, and really making sure that that's happening. So, the key to being successful is truly to be creative. Okay. So I really want us to be thinking about this. There's lots of different models out there that we can use and be creative in when we are talking about making sure that patients are getting set up and they're not frustrated. Okay. And so, sure, it can be the care coordinator. The care coordinator can go out and go to the patient's home, get them all set up for this telehealth visit, particularly the first time. I'm not suggesting that they have to do this every time, but getting them all set up, making sure everything is fine, help them finding that right spot in their house where there's good light, there's good stuff, all of those kinds of things. Or you can use a care coordination teams. And many of you may know that in Wyoming, for our Medicaid population, for example, Medicaid actually pays for community paramedic visits. So if you have a community paramedic program in your town, and there are a few towns in Wyoming that actually have certified services now and certified community paramedics, they can go out and get the patient all set up, do all of those pieces for a telehealth visit, making all that happen. And that is actually, from a Medicaid standpoint, a billable service to Medicaid to get them all set up, do their vitals, do their stuff, get everything ready for them to have that telehealth visit. So thinking about that too, that getting ready. Or community health workers is another piece, that if it was a Medicare population or another population that's paying for CCM, chronic care management, the community health worker can go out and track time and do all of these things to get things set up. So thinking about those different models of care, who's the right person, where is it, what's happening, or we can also use community resources, right? We have volunteers in our community that we can reach out to that are willing to go to Mrs. Jones' house and make sure she's all set up, doing all of those kinds of things. Be creative. Think about all these different models because it's really important. So remember I said care coordination, for example, is a time tracking modalities. Well, it's really easy for people to remember and to think about tracking time when they're actually calling and talking to the patient. Patient, time spent with the patient, that's easy. That's time trackable. I picked up the phone, I talk with them. But the regulation talks about with or on behalf of the patient. All of that time is trackable throughout the month. So there's all kinds of things. So some of that researching that chart, finding out that appropriate visit. Can it be done by telehealth? Making sure you're planning it all out, reviewing labs, doing all of those things. But the three that I kind of have in that little brighter blue there, assessing the appointment, assessing what needs to happen to the appointment and scheduling it appropriately as a telehealth visit, doing that assessment piece and saying, for this visit, it makes sense. That is time trackable. Strictly just making appointments is considered administrative, and administrative work is not time trackable. But clinically looking at it and saying, for this patient, in accordance with their plan of care, in accordance what matters most to them, and what's going to happen at this visit, it would be appropriate to do a telehealth visit. Figuring all of that out, that is time trackable. Having the right conversations with the provider. What do you think about doing this particular visit with Mrs. Jones by telehealth? She's having a really hard time getting out of the house. It's been super windy. She doesn't have a ride, those kinds of things. And for this particular visit, what do you think about that? This could be an appropriate telehealth visit. So all of those kinds of things, I think, are an important way to think about that. That's time trackable. All of these things you're doing. Driving to the patient's home or to that community visit to kind of and setting up the telehealth, that's time trackable. Now, the time actually during the visit is not time trackable. because during the visit, the provider is going to bill for the actual visit. So if you choose to stay in the home during the visit, that's not time trackable, but you don't have to stay either. So that's just something to think about. But that would be considered double dipping. You can't track time and bill for the service for the same time. That's not okay. Okay. So kind of thinking that piece. So we definitely want to manage the patient's expectations. You want to let them know what time you're going to get there or what time their help is going to get there. Maybe that's a community resource you've gotten set up for them. Maybe it's a neighbor, an adult child, a college student, lots of different things that you're going to have. What time are they going to arrive? And it is not at the time of the appointment. Okay. It's really important to understand that if their appointment with the provider is at 11 o'clock by telehealth, then all of this stuff has to be done before 11 o'clock. You don't start at 11 o'clock, right? So you definitely want to make sure that arrival time, the setup time, and then you have the time for the appointment. And if you have somebody who's going to be in the home and stay for the whole appointment, again, it's not time trackable during the appointment, but it is time trackable to be discussing all of the follow-up afterwards. So you can either, I'm going to call you when the appointment's over and we're going to talk about it, or if the person's in the home, they can stay in the home and talk about that follow-up. So it's really important to manage all those expectations, because that's one of the things is people don't understand what they're getting with a telehealth appointment. Then their expectations aren't met because we didn't know their expectations up front. So when we start talking about telehealth versus in-person visits and what that looks like, we definitely want to be looking at increasing patient and provider expectations and satisfactions and decreasing all those frustrations and inefficiencies. So let me just talk about perception for 1 second, because this I know has happened. When you go into the doctor's office, we're going to talk about in-person first. You go in, you see that there is a waiting room full of people. You get called back for your appointment. You know you have a 15 or 20-minute appointment. They spend 15 or 20 minutes with you and they leave, and that's acceptable because you absolutely were set up for that. Everything told you that's what was going to happen. You knew there were a whole bunch of other people out there. But what happens at a telehealth appointment that I've seen happen, I've heard stories from people in the field who've told me happens, because they don't see a waiting room. They have no idea how busy the provider is. They have no idea what else is going on. And actually, patients like that. They don't feel that anxiety of that frustration and all of those things that are happening. They're in their own home, they're comfortable, and they're talking to the provider. It's all great. But it can end up then that sometimes they're a little more chatty, which is good to get more information. But it can really make it so that those appointments drag on. And so because they don't understand that this is still a 15 or 20-minute appointment. So setting those expectations are important. And the most important part about setting that expectation is that you are ready on the telehealth side on time. So that you really are logged in, you're ready, you're on time, and that the clinic can then start interacting with the patient exactly when they need to. That's not the time to start connecting. It's the time to make sure your connections all work. So that's how we increase satisfaction, where we decrease some of those efficiencies. So I just wanted to throw this little bit of slide in there, because sometimes when I talk about this, people say, oh my goodness, but who has time for all that? Well, that's the point of a care coordinator. Your care coordinator is dedicated to caring for the patients that are in their program. This is the person who is responsible for the growth and maintenance of the care coordination program. And this position, I love that this next sentence that says, will work to improve the quality of life of the patients enrolled, right, through supporting those quality outcomes, smooth transitions of care, and care coordination across the health continuum. If the patients, for their quality of life, they want to have these telehealth appointments because that's what's best for them. It's best for the type of appointment. It's best to meet what matters most to them. They're more comfortable. They don't have to worry about all of those other stressors in getting out and all of these things. That's the role of your care coordinator. So that's what works really well, particularly if you have a care coordination team where they have people who do some home visits and other people who are in the office, because then your care coordinator can also be on the clinic side of that, if they're in the office, setting up that telehealth appointment so the provider really can just pop in when it's their time, just like they're rooming a patient. Instead of walking into a room, they're walking up to the computer. So really making that as clean as possible. And then if you have your people who are out in the home. So again, this is one of the reasons why I like to have that patient engagement is most important. But we engage patients by understanding what matters most to them. That's a really important feature of patient engagement and working to build on that. Next, I just am going to run through, I want to leave some time for questions and I'm cautious of the time. So I'm just going to run through really quickly a couple of slides just to show you again why I say Medicare says care coordination is here to stay. Because in 2022, from 2021 to 2022, look at this position, look at the fee schedule. So for that first 20 minutes, last year, Medicare paid $38.89 for that first 20 minutes. This year, they're paying $64.02. So take a look at that. They put their money where their mouth is, as I like to say, and that's really an important piece. And then you can also charge for additional 20-minute segments, but again, the full 20 minutes, not 19 minutes, right? So 39 minutes is going to get you just the $64, but 40 minutes will get you 64 plus 48. And you'll notice how much that went up as well. And then there's complex CCM. And again, these are for our fee schedule clinics. So the clinics who are billing off of a fee schedule, which means this is not our rural health clinics. I'm going to talk about them in a minute. This is not our rural health clinics, and this is not our FQHCs. They get paid a little differently. Same program, same concept, same everything. They just get paid differently. We'll talk about them in a minute. But complex CCM is when you really are getting that medical decision making. The medical decision making that had to happen this month to work with that patient and to do extra monitoring, all of the pieces there. You'll notice that this went up significantly, went from $88 to $134, because they are seeing that we definitely want provider involvement in a lot of these areas. And we definitely need to make sure that we're working with the provider and talking to them, and we are using their time. And in real life, what happens is these are hallway conversations that are happening, and we're actually saving that patient from having to come in for any visit, a telehealth visit or a in-person visit. And that's the other reason why they've upped this reimbursement so much. And then you'll see that you can bill for the additional 30 minutes on that complex. So I just wanted to point out, when I say that Medicare continues to grow and has continued to pay more and more, that's really important. I will also note that in Wyoming, Medicaid does pay for the CPT code 99490. It's only paying $40 at the moment, and it only pays for that first 20 minutes. It doesn't do any of those other pieces. I have, sent off my opinion and asking the Department of Health to open those codes up a little bit more. But they do, even for Medicaid primary, they will do CCM. So that's another piece that can be really helpful if we have Medicaid patients who we think it would be really beneficial for them to have telehealth visits. We can enroll them in the CCM program and really work with them around their chronic conditions and make sure they're getting the appropriate telehealth visits. I'm not going to go through all of these because I didn't talk a lot about them, but I think everyone understands the concept that behavioral health appointments being done by telehealth is absolutely working and is doing really well in both the Medicare and the Medicaid world. And so this is a care coordination program around behavioral health diagnoses. Now, these are not reimbursed by Medicaid in Wyoming, but they are reimbursed by Medicare. So the same kind of concept. If you have a patient that has behavioral health diagnoses, you certainly can enroll them, and you can see that's reimbursed for the first 20 minutes at $44. And what a great way to help them understand and maneuver and work with telehealth, because we know how valuable telehealth visits are for our mental health population. Principal care management is just like chronic care management, quite frankly, except it's only one diagnosis and it's targeted to be used by the specialty practices. And we do have some specialty practices in Wyoming that are doing principal care management. So everything I just talked about with CCM works the same way with PCM. And you'll notice that again, Medicare put their money where their mouth was this year because they went from $36 to $63. This one is 30 minutes of care coordination per month, and they're doing the additional 30 minutes. They weren't even paying for that last year. And this year they're paying for it at 48. Again, this is a Medicare reimbursement. Remote physiological monitoring. We all know remote physiological monitoring, that is a function, or at least a piece of some telehealth, right? Because we are getting data back and forth. It's not a full-on telehealth appointment. However, setting patients up, doing those kinds of things, these are all very much an important piece as well when we're looking at those. And I always like to have people doing RPM and CCM or RPM and PCM concurrently, because you may not be doing RPM forever, but you likely will be managing those patients' conditions for a very long time, even maybe even for the rest of their life. So this is a great tool to be used as an adjunct. And again, these are care coordination modalities. You can see that at least 20 minutes. And I know a lot of people do a lot of the setup in the home and those types of things. I'm going to skip over these at the moment, except to say that your annual wellness visit and advanced care planning appointments from the very beginning have always been on the telehealth list. And that's a really important thing to be thinking about, because your annual wellness visit and your advanced care planning appointments can be done by telehealth and can be done using a team-based approach to care, which means the RN in the clinic can be conducting this visit via telehealth. So the patient can be home and you can do an annual wellness visit all over telehealth with that patient. So I think that's really an important thing to be thinking about, that these services, this isn't new. These services have been telehealth approved since the beginning. And so that's a really great thing to be thinking about also, not just your providers using it for telehealth appointments, but your nurses, your care coordinators, who's ever doing your annual wellness visits, your social workers, who's ever doing your advanced care planning appointments. Those are really important. And then transitional care management is another one that has pretty much always been on the list as well. And so that is something that also can be being done by telehealth. And that is that follow-up after a hospitalization. Okay, so I promised I was going to talk a little bit about rural health clinics. So really quickly, some of these pieces, I already touched on it when I said RPM for fee-for-service clinics can be combined with CCM or PCM. So you can be doing a couple of these. You can be doing TCM alongside those. You can be doing BHI and kind of making sure all of these happen. If this is the same provider, you absolutely can be billing for all of these different service modalities on there. That is not the case when it comes to our rural health clinics or our federally qualified health centers. For rural health clinics and federally qualified health centers, they actually made it easier for you, quite frankly, because they created, it's all the same rules, all the same pieces, but they kind of created this combination and they call it care management. And so all under care management, irregardless, they don't care if you're doing CCM or BHI or PCM or any combination of these, it is one code in the month, and that is called care management for them. So even if you are a rural health clinic, everything we've talked about still absolutely applies. It's all still time tracking. And so for care management, again, it's any one of these combinations. It is reimbursed at $79.25. So you'll see that they pay more. They pay more to rural health clinics, but they don't care what combination or any one of those that you would like to do. And the collaborative care management is that mental health piece. So again, when we're talking about rural health clinics, just really quickly, that all-inclusive rate, which is how you get paid for the annual wellness visit, that all-inclusive rate for or any of your telehealth visits, it has gone up a little bit to that $113 for that visit. Now, again, if you were a rural health clinic prior to this rule, it's whatever your air payment was set at for your cost base. So why I went through those numbers really quickly, or I intended to be quick, I hope it was quick enough, was to let you know where's this money coming from? As we talk about, yes, who's going to do this? Who's going to be able to help the patient with their telehealth needs? Who's going to make sure they have the connectivity? For some of those patients, who is going to be able to go out and help them get set up for that first visit in their home? So when we start to look at our fee for service people, we're looking at doing annual wellness visits and advanced care planning and care management for them over the course of a year, brings in about $1,150 into your practice for one patient over the course of a year. So I just want you to have that kind of in your head. If you're a rural health clinic or a federally qualified health center, although the federally qualified health center, your air payment is going to be a little different, but in the ballpark, you're getting reimbursed the same in these others. It's close. It's still about the same, $1,174, a little bit more money. So when we start talking about being efficient and being able to manage 200 patients and tracking time for 200 patients and getting them all lined out and squared away and organized for a one care coordinator, you can bring in about over $200,000 into your practice. So when we get to about 175 patients or so in a practice, that's when I like to tell care coordinators, it's time to review your patients and start thinking about that community health worker person. Maybe are you already doing some home visits? Are those home visits things that you could use a community health worker to do, an MA, a CNA, an EMT? What kinds of people would it make sense? Because you clearly can cover the salary of an RN and a community health worker at 200 patients or more. So I think it's a really important piece to make sure that that is happening. And then I'm going to take it full circle all the way back to that quadruple aim, because I will tell you, when we have set expectations with patients, because it's what they want and it's the expectations they want, they become way more engaged in their own care. We as care providers are way more satisfied with the work that we're doing. We're less frustrated. Patients are less frustrated. It really does help to prevent burnout and really does help to make sure we're meeting that middle of that quadruple aim, which is ensuring practice work environments for those delivering care. So we really want to prevent burnout and team-based care and being able to do really good planning and being able to engage patients. Here's a really good article that'll show that when you do all these kinds of things, you have a much more rewarding practice and your own personal work satisfaction is way improved. So with that, I will stop sharing my screen and I would love to entertain any questions.
It looks like Rochelle has a question. She says, in terms of numbers, how many patients can a typical CC manage and do CC well?
So the productivity number is 200. So 200 for a care coordinator, but I like to have people start really thinking about bringing that second patient in somewhere around the neighborhood of about 150, 175 patients. Once you have that many patients that you're doing care coordination on, and in an efficient way, using the right tools. I mean, that's part of it. If you're trying to do care coordination and you're trying to track all your time and do all that on a spreadsheet and you're not using the right tools, I will tell you, people using things with a spreadsheet can hardly get above 50 ever. I've never seen people be able to do more than that. And the problem with that is at 50 patients, you're not covering your own salary. And so it's not a sustainable program. And that's really a problem because we want this to be a sustainable program. So you do need to use the right tools and you do need to make sure that you are indeed being efficient and that you're tracking all of those things. So that number I showed at the end, 200 patients for getting all three of those modalities, some by telehealth, some by, with care coordination, all of those pieces. You're going to bring in about $230,000 into your practice. So that's where we say one person could manage that, but I like to start bringing in a second person right around there. And what is the second person? Doesn't have to be another RN. Sometimes those community health workers who can go out and do things like help set up telehealth, help make your practice run more efficiently, and at the same time still be able to track time to have billable months for those 200 patients is really important. So that's where I like to start advising people and start having discussions about who's the right next person because of your patient population. Maybe you don't need people to go out to the home. Maybe that's not your patient population. Maybe you have people who are just needing lots of medication interventions. Okay, well, then maybe you need another RN. Maybe you have people who just need help with setting up med boxes. Well, then maybe you need a community paramedic or an LPN, because an EMT or a medical assistant can't do med boxes, right? So thinking about what is it that you need when you get that second person. But the math will say 200 maxes you out. You can't do more than 200. So hopefully that is helpful.
So
Okay.
just as a reminder to everyone, this presentation will be sent out to you so you can see the codes that are involved that Faith shared, but this was incredibly helpful. I think the presentation was fabulous. And as always, WyTN is here to help with implementation or sustainability of your program. We have a lot of great people that we can connect with, like Faith. And so if we don't know the answer to your questions, we know someone who likely does know the answer. So reach out anytime. Don't forget to join us next month, as we will be hearing from nurses and we will be hearing about different ways to create workflow and to do implementation. We're very excited about it. And Faith, thank you so much for today. It was wonderful. Thanks to all the attendees, and we'll see you all soon.
Thank you.